Hello YouTube, welcome to Dr. Vibes, a learning point. In this video, we will study about the causes and the management of abnormal uterine bleeding.
So in this video, we will study about abnormal uterine bleeding, that is IUB. So suppose a patient has come to your OPD and saying that there is abnormal bleeding from the vagina. Doctor, please treat me. So as a doctor, you should first know whether this is a case of abnormal uterine bleeding or not. Now what is called as abnormal uterine bleeding? For that you have to know what is normal uterine bleeding. So any bleeding which lasts for 2 to 5 days, in which you have to change for like 3 to 4 pads every day, and which is having a 21 to 35 regularity of the cycle, is called as normal uterine bleeding. So what is abnormal uterine bleeding? Any bleeding from the vagina which is not related to pregnancy and which is abnormal in amount. That means you have to change more than 6-7 pads per day, which is abnormal in regularity and frequency. I told you that the normal cycles repeat themselves at regular intervals of 21 to 35 days. So anything which is coming less than 21 days and anything which is beyond 35 days and which is abnormal in volume. So normal volume is 20 to 80 liters. If it is less than 20 or if it is more than 80, you call it as abnormal. So I repeat the definition of abnormal uterine bleeding again. Any bleeding from the vagina which is not related to pregnancy and is abnormal in regularity, frequency, volume, which is associated with clot, which causes the hemoglobin level of the women to go down, is called as abnormal uterine bleeding. Now there are various causes of this, and as a doctor you should know how to treat those causes. So what are the causes? That is given by a mnemonic called as palm coin, wherein P stands for polyp, A stands for adenomyoma. What is adenomyoma? Adenomyoma is basically a functioning endometrium that is present in your myometrium of the uterus. What is L? L is leiomyoma, that is fibroid. M for malignancy. C for coagulopathy or coagulation disorders. O for ovary dysfunction. I for iatrogenic causes. N is not specified. And E is endometrium dysfunction. Now, as a doctor, you should know how to treat these conditions. So we will start with polyp first. So this is the management of the polyp. You have to first see whether the patient is symptomatic or asymptomatic. Now, what can be the features or the symptoms of a patient who has come with polyp? Obviously, we are dealing with the abnormal uterine bleeding. That means there will be abnormal bleeding. What can be the abnormal bleeding? There is heavy menstrual bleeding, or there is intermenstrual bleeding. There is postcoital bleeding. Along with that, a polyp will also present as maybe abnormal vaginal discharge or infertility if there is multiple polyp. So if these symptoms are present, then the option that you have is hysteroscopic polypectomy. That means you will remove the polyp. If the patient is asymptomatic, you have to do a USG and find out the size of the polyp. If the size of the polyp is less than 1 centimeter, then you can just wait and watch, because the polyps can regress away on its own. But if the size is more than 1 centimeter, then you have to go for hysteroscopic polypectomy. Now, if you're a postmenopausal woman and if you're having a polyp, you don't need a uterus. So basically, you can go for heteroscopic polypectomy. Now, after the polyp has been removed, you send this polyp to for biopsy. And if you find that this polyp is benign, then you have to give LNG ICS, that is levonorgestrel intracortical steroid. And if the polyp is malignant, then you have to treat it as a malignant case. So this is the management of polyp. Now we move on to the management of adenomyoma. Now in case of adenomyoma, that is the functioning endometrium, when it is present in the myometrium, you have to see or check whether the woman desires fertility or she does not desire fertility. If she does not desire fertility, it's very easy. You can just do a hysterectomy, that means remove the uterus, or you can also do transcervical resection of the endometrium. This is basically an ablative procedure of the endometrium. Now, if the woman desires fertility in future, then you first start with LNG ICS. If that fails, then you can go for GnRH agonists. That means surgical treatment is when the patient does not desire fertility, but when the patient desires fertility, you have to go for medical management. This is the treatment of adenomyoma. Now, let's move on to L, that is leiomyoma or fibroid. So just like polyp, you have to first see that the patient is asymptomatic or symptomatic. What are the symptoms of fibroid? The symptoms of fibroid are almost similar. That is, most of the patients will be asymptomatic. There can be heavy menstrual bleeding. There can be pain during menstruation. There are chances of infertility as well. Also, there are features of urinary retention and incomplete passage of the urine. But usually no vaginal discharge is present, which may be present in case of a polyp. Okay, so if the patient is asymptomatic, that means if symptoms which I've just mentioned now are not present in the woman, then you have two options. You just do either supervision or you can do surgery. What are the indications of surgery? These are listed below. For example, if this is a case of a pedunculated subserosal fibroid, if the fibroid is of a large size, say more than 12 weeks when you compare it with the pregnant uterus, or if there is uncertain diagnosis and uncertain infertility, these are the indications of surgery in case of an asymptomatic patient of fibroid. If the patient is symptomatic, there are two options available again. You have medical management and you have surgical management. Medical management is temporary. Obviously, the surgical management is a permanent one. What you can do in the medical management? You have GnRH agonists, you have GnRH antagonists, you have progesterones, you have ulipristal, mifepristone. And here are the indications which are given for medical management. Obviously, if the patient is not willing for surgery or the patient is unfit for surgery, if the patient's hemoglobin level is too less, you can't take her for surgery. So these come under the medical indications. Now, what are the surgical options for a fibroid patient who is symptomatic? You have myomectomy, that means you just remove the fibroid. Or you have hysterectomy. You perform this hysterectomy in the case of a postmenopausal woman or women whose family size is complete. You also have some minimal invasive procedures like uterine artery embolization, where you cut the uterine artery or embolize it so that the fibroid doesn't grow further. Or you can also have myolysis. So this is in short the management of fibroid. Now we move on to the fourth cause of AUB, that is malignancy. So what you have to do in the case of malignancy is the endometrial assessment by biopsy. So basically you take out the part of endometrium and send it for histopathological examination. Now this histopathological examination of the endometrial tissue is done in women who are more than 40 years of age, or if a woman is less than 40 years of age but she's having certain risk factors. What can be the risk factors? Needless to say, it has to be hypertension, it has to be diabetes mellitus, it has to be PCOS, obesity, and some other conditions like maybe malignancy or irregular bleeding, and the endometrial thickness is more than 12 millimeter. So if a woman is less than 40 years of age and is having any of these, you have to send the endometrium for histopathological examination, because these indicate that there can be chances of malignancy. Or what you can do is dilatation curettage, but this is not usually done for endometrial assessment. Lastly, if nothing works out, you can do a hysteroscopy as always. Now this will tell you the condition of the endometrium. If it is malignant, you have to treat it as a malignant condition, that is you have chemotherapy, radiotherapy and surgery. And if it is not malignant, then you have to find out the other causes of AUB. Now, out of the mnemonic PAM coin, PAM is done. Now we move on to coagulopathy. Now, in case of coagulopathy, you basically need to consult one hematologist. And there are two solutions for it. One is the non-hormonal method and the second one is the hormonal method. In non-hormonal method, you basically just control the bleeding by giving tranexamic acid, or you can also give mefenamic acid. We know that these drugs control the bleeding. Now, if you want to go for hormonal procedures, you have two options again. One is give the LNG ICS, or you can give the OCPs. And this is a refractory case. Both non-hormonal and hormonal management doesn't work. Then you can think of some other conditions like von Willebrand disease, which is causing the coagulopathy. Here in this case, you have to do the factor replacement, or you can give the desmopressin. Now we move on to the next cause of AUB, that is ovulatory and endometrial dysfunction. The management of both ovulatory and endometrial dysfunction is almost similar, wherein first line drugs that you can give for such conditions are the OCPs. See, here you have the combined oral contraceptive pills, which are given for 6 to 12 months. Here also you have the same combined oral contraceptive pills, that is in case of the AUB due to endometrial dysfunction. And the second line option is the cyclical administration of norethistron. Okay, this is given for 21 days. Same for this case, you have to give it for 3 cycles for 21 days, cyclical norethistron. So this is the management of the AUB due to ovulation dysfunction and AUB due to endometrial dysfunction. Now we are left with 2 more cases. One is iatrogenic and the second one is non-specified. The treatment of iatrogenic cause is very easy. You just have to give LNG IUS. Do you understand what iatrogenic means? It means either there is estrogen breakthrough bleeding or there is progesterone breakthrough bleeding. So you just have to give LNG IUS. Now we move on to the abnormal uterine bleeding due to a non-specified cause. Now here I would like to draw your attention, and if you're watching the videos at a high speed, then I would say that please reduce your speed, because this is an important and slightly confusing topic, that is abnormal uterine bleeding due to a non-specified cause. So suppose a woman has come to you and you don't know the cause of AUB. You have surgical option, you have medical management. In medical management, the first line is the LNG. If that fails, you give GnRH agonist. Simple. I'm so sorry. So yeah, if a medical management is given in case of AUBN, first you give the LNG IUS, which is the first line treatment, and if it is contraindicated or if it fails, then you have to give the COCs, that is combined oral contraceptive pills, that is the second line treatment, and not GnRH agonists. Now, if the person is moving to surgical treatment, then you can do ablative procedures in case of surgery. Now, if the surgery is failing, ablative procedures are not working, or if it is contraindicated, then you give GnRH agonists. So one thing I can assure you, that in a woman with AUB, you have medical management, you have surgical management. In medical management, you start with LNG IUS, you can go on to COC. If these two fail, you move on to GnRH agonist. Similarly for the case of surgery. If surgery fails or contraindicated, you move on to GnRH agonist. So GnRH agonist is never the first line treatment. It is always a treatment when either medical or surgical management fails. Now, what is the treatment of AUB due to N? Due to AV malformation, you can do a uterine artery embolization. If this fails, you can do hysterectomy. So as I told you, that hysterectomy is the last resort. Now, if AUB is cyclic or predictable, then you can give some non-hormonal options. You don't have to give LNG IUS, COCs, GnRH agonists. You can go for some non-hormonal options such as NSAIDs and tranexamic acid, which can just reduce the bleeding. So I hope you find the video of AUB useful. What are the causes of AUB, what is AUB, and what is the management of AUB? The management of AUB is really important, so watch this video many times. Thank you.